SVT for long periods of time, then the baby can have congestive heart failure. So your answer there is A. Okay, and we'll talk about antepartum fetal surveillance considerations. The goal with that is to identify women at high risk for stillbirth, decrease the risk of fetal demise after 24 weeks gestation, and avoid unnecessary interventions, which to me is kind of an oxymoron because you're doing surveillance, usually NSTs or BPP. I guess they aren't interventions in the sense that they don't harm you in any way, but you're still here doing stuff. So initial testing occurs at 32 weeks, 32 to 34 weeks, and is appropriate for most. And that's appropriate for most. But sometimes they'll start as early as 26 to 28 weeks, and it'll depend on the patient's history. If they had early losses, stillbirths, things like that, they'll start that early. When the clinical condition that prompted testing persists, a reassuring test like a reactive NST, a negative CST, which means negative for anything untoward, a normal BPP should be repeated 1 to 2 times per week depending on the test and the high-risk conditions until birth. And we're seeing that in testing and triage. Okay. Here's some, but this is not all-inclusive, some pregnancy-related conditions that would merit prenatal testing or surveillance. If they have pregnancy-induced hypertension, which is everybody almost, decreased fetal movement, oligopolyhydramnios, and so many of them have low fluid, intrauterine growth restriction, post-term pregnancy, which not many of them get to post-term anymore, isoimmunization, moderate to severe, previous fetal demise or stillbirth, which is a big reason to do NSTs, and if there's multiple gestation, especially if there's some growth discrepancy, if one of the twins is bigger than the other. More maternal conditions continued. If they have the antiphospholipid syndrome, which is something that's screened for, if they have multiple losses, they would be screened for that, and then that's something you would know. If they have hyperthyroidism and it was poorly controlled. If they have hemoglobinopathies like sickle cell or sickle trait or something like that. If there's someone that has significant heart disease, and really that would be someone who wouldn't necessarily be a candidate to deliver here. Systemic lupus, hopefully that patient would have been screened to make sure that baby doesn't have any heart anomalies. Chronic renal disease, and we do get some of those. We've even had ones that have had kidney transplants. If they have insulin-treated diabetes or hypertensive disorders. And a lot of our patients are gestational diabetes, diet controlled, or we have ones on insulin quite a bit, and a lot of our patients have high blood pressure, but not necessarily diagnosed hypertensive disorder. All right. Fetal movement counting. Oftentimes the offices will give them kick count charts or little handouts that says for them to keep track of the baby's movement during the day. It's based on maternal perception of fetal movement. So you know it's not perfect. We have a lot of patients that just don't feel their babies move. I don't know why. Sometimes they just tune those out, and maybe that's just a protective measure because when your baby's scrambling around in there, that can drive you crazy if your baby is constantly moving. A decrease in fetal heart or fetal movement may, but not necessarily precede fetal death, but in some cases by several days. And then there's lots of protocols, meaning providers have their own gauge or their benchmarks of what they want, how many movements they want, and how they want their patients to count it. But often they are supposed to have 10 perceived movements in a period up to 2 hours, and that's considered reassuring. All right. So here's a little kick count chart. And during the day, this patient is kind of charting at the same time, around 7 to 7:30, and then they are writing how long it takes them to feel a movement. So as it gets to the end of the week, it looks like it's trending a little longer till they feel movement. There was a question about, I'm going to go back to that in a minute. If they haven't changed a lot of the questions too much, there was a question on the test about that. And it asked about fetal kit counts, and it showed a chart where there was definitely a decrease in kit counts. And what would you advise the patient to do? Would you have them lay down, check another hour, call the doctor tomorrow? And the right answer there is if they saw a significant decrease, you would encourage them to come in.